Dr. Clearfield for letting me come here and share what I've been working on the past couple of years. I do have to credit Dr. Gordon for helping me with this, developing this program that I have. But yeah, the title is Using Precision Psychiatry to Improve Mental Health. Why I said that versus disorder, basically, because I think all of us can benefit from good mental health. So this approach is just not for people who are struggling, but for people who are wondering, hey, how can I think clearer and so forth. So let's begin. Um, I think Dr. Clifford, I love how you put those little interjections in my bio. So I don't think I need to talk more about this. I thought that was a little fun. To even have more fun, I want to talk about where we came from. So leading towards precision psychiatry. So 7,000 years ago, we had something called trepanation, which is boring a hole in the skull and trying to release pressure that way because they thought mental illness was somewhat demon driven. And so this also helped to relieve headaches. And in the 1600s, we have bloodletting, another concept that mental illness was a chemical imbalance. So, and they thought letting it bleed out was the cure. I mean, the concept was right, but not the treatment. And 1948, this is John Gade. He was an Australian psychiatrist. This was the first psychiatric medicine that came out. It is lithium. So now we move on to the first antidepressant. It was an MAOI inhibitor called iproniazid. This medicine really was by accident. What happened was it came from a tuberculosis medicine, and they gave it to all these patients at the sanitarium, I think in Lexington. And they noticed people were perking up and being happy. However, some did get manic, so they thought, okay, maybe we can tweak it so it can be a psychiatric medicine for depression. The first antipsychotic was in 1952, chlorpromazine, that came from Benadryl. And what I also found out too, they came from methylene blue. So there could be some anti-inflammatory properties in that medication. And first used in Paris. Same year, tricyclic antidepressant. This came from chlorpromazine, which is imipramine. Good medicine, sort of. However, it's very sedating. We don't really use it a lot because of the fact that higher dosages, it could be effective, but makes people sleepy. So now we basically use it that way. And the lots of drug interactions and overdoses, you could have risk of arrhythmia. So not really first line, but it's an option. But in 1987, the first antidepressant SSRI was Prozac. Prozac was revolutionary in a sense because it made mental health a little bit more streamlined, a little bit more available. And so we had the ability or access to treatment with medications, not just therapy anymore. Pros are, less sedating. It is safer, even in an overdose. Cons are, it takes time to build up, GI side effects, and of course, most people complain of what? Sexual side effects or even apathy. They don't care. Too much serotonin. That's what happens. So let's talk a little bit about, I disappeared. Do you know what happened, Mike Clark? I need your help here. The thing disappeared.
We have Freud on the screen.
Okay, all right. It's just that my screen is missing. It just went that way.
Kyle, can you help us out here?
So it looks like you still have your screen up because you're sharing a singular tab.
That's fine.
So
Okay.
you're all set.
As long as you guys can see me. Okay. All right. So yeah. So let's talk about non-medication treatment. We got Freud, father psychotherapy, overall effective, but not 100% because patients sometimes they're too depressed to even participate or too anxious, and they still need medications. Other thing is ECT was revolutionary in itself because triggering a seizure changes the brain chemistry. And believe it or not, insulin was used to first trigger the seizure in the beginning. A little safer now, though. Then, of course, we have this lobotomy. Lobotomy was dangerous. So it really didn't do anything other than put people in a catatonic state. Rosemary Kennedy is one of the most famous ones, the sister of JFK. She wound up being institutionalized the rest of her life. So we do have options for mental health treatment. But this is what led me to the road of why I needed to go further in my knowledge. So despite of all these treatments, there's such a thing as treatment resistance. And how do you define that? That is people who are unresponsive to traditional treatment. So some scary facts, and it gets even scarier as I talk some more about it. Depression supposedly is 30% treatment resistance. However, the STAR-D study that talks about the mother of all antidepressant study, and it's like the cascade of what we need to do. If this doesn't work, then we add this and that. They found actually the rate is 55%. And to put it in perspective, 10 million Americans suffer from treatment resistant depression. And there's 20 million Americans diagnosed with MDD. So really the number is 50%. Anxiety, 50% treatment resistance. And bipolar disorder, it's really the more dangerous ones, especially when it comes to depression. 2/3 don't respond to first line treatment. So let's talk about the worldwide state of mental health. 1/10 lives with a mental disorder. That's about 970 million worldwide. In COVID, the anxiety rose by 26% and depression rose by 28%. What makes it even worse is that when you get the wrong treatment, it makes things worse. It changes the brain, not for the better. It can worsen the episode, as well as the episodes can get more frequent. And mental health and mental illness, the problem with it is this doesn't affect the patient. As we know, it affects caregivers, it affects loved ones, and it affects society in general. So let's talk about the impact, the psychiatric impact on society. This Journal of Psychological Medicine says mental disorders is the leading cause of disability in young people worldwide. The Lancet says by 2030, the annual global cost of mental disorders are estimated to be 6 trillion. That's pretty big. And then in June 2020, Journal of Psychiatric Research says mental disorders magnify the risk of multiple other chronic conditions, including what is a problem with heart disease. So I saw this also. I mean, I don't even need to know these statistics, but I saw this in my patients that current modalities was just not working. And so I had to go on a journey to really figure out how to help my patients. So I started with genetic testing. Genetic testing was great. However, what I know now compared to what I know then is really kind of backwards. And I was using it to say, okay, take this medicine because you can metabolize this and that. I was still not getting the result. So then I added what they call integrative medicine for mental health. that is what we call holistic psychiatry. You know, we tell people they got to eat right, sleep right, exercise. They got to take in their physical aspects of the patient. And the focus is on supplements. However, even with supplements, sometimes we don't always get it right. So I added TMS. TMS has a 60%, so it's a little better than 50% for medications, success rate. What I do like about it, you know, it stimulates the electrical activity of the brain through magnetic stimulation. It targets the DLP, the dorsolateral prefrontal cortex, to help release all the good neurotransmitters. But it also modulates GABA and glutamate. And the best thing about it is it does increase brain healing. However, TMS may not always be successful. So then I went on another journey, and that's where I learned about hormones. And I knew that that was a missing piece, but I just didn't know how to incorporate it. And then I took Dr. Gordon's class of traumatic brain injury, and that was revolutionary. But even that, not considering everything else, there's still not a good option for my patients, because some patients can't even tolerate hormones because I wasn't looking at certain things prior to adding that. So I kept just going and going and kept learning. I found out that genetics can play a factor in what supplements to give patients, as well as knowing running the labs is what will also guide what we give our patients. And then genetics can also tell us how well a patient will respond to TMS, how we can get the brain prepared better for TMS. And because it is good, increasing the brain-derived neurotropic factor, it is good for patients who have traumatic brain injury, who are poor secretors of BDNF. And then hormones, I added. Sometimes you do have to think about genetics when it comes to hormones. So I started seeing a pattern that these things do affect one another, and you have to go from one step to the next in order to get the patient better. And then so I was thinking, what is this? And then I came across this concept, precision psychiatry. And I was like, this is what I do. I didn't know that. But how you define that is using biomarkers and labs to get the root cause of the psychiatric symptom to get the correct treatment. So on the left here, we have a triangle. You start with a doctor, and the focus is on pills, driven by the DSM criteria of UME criteria for MDD, generalized anxiety, ADHD. However, we flip it around. What we do is that we use biomarkers to guide our treatment, to even be a more holistic approach. And this way we can say, oh, you just need therapy, medication, supplements, or you need to do more lifestyle. So we find a broader option for a mental health solution. So that's exciting. The whole point is precision psychiatry really gets into the neurobiological mechanism of what makes people sick from a psychiatric disorder. So when we understand the mechanism behind it, we have the foundation for the treatment. And then we can target whatever is making that patient depressed or anxious. And we can even treat some of those symptoms that were not treatable before, as well as you can control the symptoms better because you know the underlying cause. And sometimes you can alter the trajectory of the disease, meaning that you can stop it from getting worse. So where did it come from? It emerged from precision medicine, so we borrowed a lot from them. And as we know, with precision medicine, we have to consider biology, lifestyle, environment, and social determinants. But in the end, understanding all these things, we can improve diagnosis, we can get more accurate treatment, and even prevent mental health conditions or prevent the next episode much better. So I like this slide because it kind of just gives you an idea of how precision psychiatry works. You got all these disorders, and then you have to run lab data or any kind of data, get your history, get the medical history, talk about their life experiences. If you have access to it, CT scans, functional MRIs, SPECT scans, as well as doing neuropsychological evaluations, and then run your labs and genetics. And from there, you can biotype the patient into who they are and what is best for them. So they get that personalized treatment, whether it's medications, therapy, psychotherapy, neurologic rehab, or something else. So the whole thing is you take away the approach rather than focusing on diagnostic criteria that is symptom based, syndrome based, so we can focus on solutions. And it's critical because there's so many things that do affect how we get anxious, depressed, ADHD, can't remember, and all that. There is a think tank for this. It's called the Center for Precision Psychiatry. What they are is their mission is, this is from, of all places, Harvard, Mass Gen Hospital. Their mission is to integrate research and clinical practice to be able to have a more accurate risk prediction, target prevention, have precise diagnosis, and have effective treatment for psychiatric disorders. There is a book, and it's still in the early stages, but it does talk about all these things: neuroimaging, electrophysiology, neurocognition, inflammatory markers, pharmacogenetics, behavioral science, machine learning, pharmacotherapy, neuromodulation, neuroscience. All of these are examined well, and then what implication, how we can use in psychiatry and future areas of advancements. So I like to think of precision psychiatry. We're moving away from the one size fit all. It's no longer that. It is individualized treatment. And one thing we need to understand is that there are three components of it. And that is stratified medicine, identifying the groups of patients who will benefit from a certain kind of treatment; personalized medicine, genomics to select treatment options with the greatest likelihood of success; and precision mental health, as we take that and we know what the treatment as the diagnosis is, and then also use it for prevention, sometimes prevention of a worse outcome or ever having it happen. And there are three goals in precision psychiatry: precise classification, we need to know what has gone wrong; precise treatment planning, how can we fix what's gone wrong; and precise prevention, how we keep things from going wrong. So there are US federal initiatives that have come about to try to help push this along. The National Institute of Mental Health has a research domain criteria initiative, the BRAIN initiative from NIH, the Human Connectome Project, and actually the VA. The ACT, Commander John Scott Hannan Veterans Mental Health Care Improvement Act of 2019. So let's talk about the Research Domain Criteria Initiative. Really, what they do is they investigate mental disorders to try to come up with new research so you can have a better diagnosis, prevention, intervention, and cure. And they want to say this is not a diagnostic guide. It's not replaced the DSM, but it helps people understand better the nature of the mental health illness, the varying degrees of dysfunction, and the psychological biological system. I found that even some of the things in a psychiatric diagnosis, I really think truly too, even those syndromes, there is a biological basis for some of them. So the brain research through advancement innovative neurotechnology, what this is its mission is to revolutionize our understanding of the human brain. It's a combination of federal and non-federal groups, and what they want to do is to accelerate the development of innovative neurotechnology. And with that, they can create a dynamic picture of the brain, of the individual cells and neural circuits. The Human Connectome Project, this is held by the Connectome Coordination Facility. It houses all this public research. There are about 20 of those human connectome studies. And what they do is they really want to focus on mapping the brain so they can understand where circuits go wrong in the structure and how it explains behavior in people. So the VA, they got into the Act 2, and this Act in 2019, it implements and tells VA providers that we need to implement precision medicine to identify and validate the brain and mental health biomarkers. And they wanted to consider these conditions: depression, anxiety, PTSD, bipolar disorder, and traumatic brain injury, which is a huge thing in the veterans, which kind of leads to all of those things. But they also wanted them to have a focus on using these biomarkers, and they recommend, functional MRIs, EEG, genetics, other biomarkers, such as labs. And one thing that I do appreciate about precision psychiatry is that it removes the stigma of somebody suffering from depression, anxiety, mood disorder, substance abuse. It's really eye-opening when I see my patients and I show them, okay, this is what's wrong with your genetics, this is what's wrong with your labs, this is what's wrong with your hormones. And some of them just cry because they have suffered from mental illness for so long, going from doctor to doctor. And then they just say, so it's just not me. It's like, yeah, it's not just you. It's just that you cannot will yourself to get better because these things are blocking you from getting better. So when patients see what is it that's causing these things, and they see these labs and they see this objective data, it kind of empowers them, and it actually gets them back into treatment. And if you explain to them what the implications are of certain things going on in their genetics and in their labs and in their hormones, you get them to actually be more compliant, as well as to even you work with the patient collaboratively. So you actually are taking away from the patient from being able to share why they feel depressed, and take away that shame and be able to just talk about their mental health. So what is the cost of this? In the American Journal of Psychiatry in April 2018, the APA task force wanted to look at, what will this take? And they took randomized control studies from 3 genetic testing companies. They found when they reviewed everything, you could save anywhere between $1,300 to $5,000 a year. And doing this will increase quality of life in the patient. The other thing that why we can save money, because we can save time, because we know exactly what to give the patient. No more experimenting, no more throwing a dart and seeing what sticks. And then, as I talked about, mental illness is a great disability in people. So you get them better, get them functioning, and they are working and they are enjoying life. They're participating in life. So I wanted to talk about how is it we do this in clinical practice. There's still not a lot of access to precision psychiatry. So we do use two main things right now in clinical practice. One is neuroimaging, and I just want to share this. These are SPECT scans. Dr. Amen, he's an expert in it, and he can look at a SPECT scan and tell me, hey, this is what's wrong with your brain. You have this kind of ADHD, and he gives his cocktail. So that's one way. The other way is pharmacogenetics. And this helps us make decisions of what meds to give and what meds to avoid. So it is still in the infancy stage. And in my practice, I do lean more on pharmacogenetics because I don't really have access to neuroimaging. My patients can't really afford that. So what I do like about my way of practicing precision psychiatry is that you can take this practice to the big city, to the rural areas, so long as you have access to labs and genetics and so forth, you can do it anywhere. So I'm sure the question is, how do you really use it? So let's talk about this, because there's different ways to do precision psychiatry. As we see, there's neuroimaging, but that's still in the infancy stage. And then there's running the labs, and then there's the genetics part. So I start with genetic testing because I need to know what I'm working with. And what I've done is that I've changed my way of thinking about genetic testing, and I'm going to get into that later on. So then I do my brain mel panel. That is a ton of labs that checks on your basic things, as well as inflammatory markers and hormones. And then if needed, I will do environmental tox panel. So many patients are diagnosed with MDD and they have fibromyalgia, and that's the diagnosis everybody wants to run from. But actually, now that I have patients that have these things, and I'm always curious, I was like, oh, you have fibromyalgia? You have rheumatoid arthritis? I wonder what's causing that. So I've come to learn that, toxins can really do a lot of damage to a person's mental health. So let's talk about pharmacogenomics. It is the field of study that combines pharmacology and genomics. It explores how genetics may influence a response to a drug, as well as it is precision medicine / psychiatry. It emphasizes personal care based on specific characteristics, such as genotypes. So the question is, does genetic testing work? Well, there's all kinds of data that says not, but then there's data that actually says it does help. Here in American Journal of Managed Care, pharmacogenetic guided intervention associated with increased adherence and cost savings. So what they did was they studied, they looked at a bunch of claims and compared the ones that had genetic testing versus the ones that didn't. The ones that did have genetic testing, they were more adherent, and it was cost savings of 9.5%. So they concluded that it's actually okay to use it in everyday psychiatric clinical practice. Here's another one, Journal of Primary Care, naturalistic study of the effectiveness of pharmacogenetic testing to guide treatment. And this was like real world data. They wanted to know what the effectiveness of genetic testing is in the real world, and it's how to assess its impact on treatment decision. So just, fortunately, it was an unblinded but prospective study of psychiatrists who used genetic testing on their patients. But they did measure the CGI. 87% had some measurable improvement, either minimally much improved or very much improved. And 62% was in the much improved and very much improved group. So They concluded it does improve symptoms, less side effects, and also greater quality of life. One last one I want to share. This is one of the later ones. In January 2018, they reviewed pharmacogenomics. It was a review of pharmacogenomics and psychiatric clinical care. They said recent evidence suggests that using genetic testing for psychiatric illness improves patient outcomes, decrease healthcare costs. So there's a lot of benefit. Remember what I talked about? It's just not only finding the right medicine. We're cutting the time to try to find the right treatment for the patient. So that's how you can also cut costs. So what I did before was I looked at pharmacokinetics. And so if anybody's ever seen a genetic testing for mental health, it's always in like different columns of what medicines you can give. And a lot of it was based on pharmacokinetics and how the drug moves within the body, what the drug does to the body, and the 4 stages of absorption, distribution, metabolism, and excretion. However, I did not always get the best results. So what I did was I flipped the script. I focused on pharmacodynamics, which is the effects of drugs and their mechanism of action. What the body does to the drug. This is the relationship between neurotransmitters and receptors. And then oftentimes too, it's not just receptors, it's the transporters that are involved in neurotransmitter movement. So this totally changed my way of thinking about how to use genetic testing. And with this, I'm actually able to use natural supplements that actually treat the issue from the beginning without having to resort to psychiatric medications. To me, that's the last resort now. And it's unfortunate that my colleagues actually use genetic testing as the last resort. And then APA, they came out with something recently that said, you still need to use this as the last resort. And I'm like, you know what? You're not using it right. You have a tool that you need to learn how to use. So just an example, I use this a lot in kids because some of these parents don't want their kids to be on medications. So I had a case where his little 6-year-old boy, he was running and doing cartwheels in my office. And I was like, oh boy. So I ran his genetics, found out what was wrong because he was getting threatened to get kicked out of school already in kindergarten of all things. Found out what the issue was, gave him natural supplements. It was like short of a miracle the next time he came and seen me. Like he was calm. Dad reported he's no longer being threatened to, get kicked out of school. And he didn't lose his personality, because I think that's the problem with sometimes when you give psychiatric medicines, you tend to lose yourself. And that's why some people are afraid to take it. So I want to just focus on 3 genes today, because these are the ones I really like to really make sure I know what's going on there. There's some other ones, but for time, let's just talk about the top 3 that I look at first: BDNF, MTHFR gene, and the COMT gene. So let's talk about BDNF. What is BDNF? It has a function of increasing neuronal survival after brain damage, neurogenesis, migration and differentiation of neurons, and growth of dendrites and axons, and synapse formation. So you think of BDNF really as a fertilizer of the brain. It helps generate new brain cells. It helps with connections. There are people who have what they call altered BDNF. And the genetic component of it is Valmet and heterozygous. That is really, you think of heterozygous as like the normal common thing, but at this time, heterozygous is not a good thing, versus people, majority are homozygous Val. So what happens? Met carriers, they often have low BDNF levels in the brain. And what are the symptoms of low BDNF when you're talking about a brain that's not given the fertilizer to grow? You have depression, mood instability, anxiety, cognitive impairment, and inattention, as well as memory loss. So I just want to talk about a couple of treatments for BDNF because I think we're like, what do you do with that, right? So I found out a couple of things that we can do. Lithium. They found it in the Journal of Alzheimer's Disease. Lithium increases BDNF in early Alzheimer's. Intermittent fasting. This article, not too long ago, 2021. Intermittent fasting is shown to increase BDNF, as well as interval training. The exercise releases beta hydroxybutyrate and it turns on BDNF promoter. The other thing I learned is that recently, because when you're exercising, you release lactic acid, and supposedly that also stimulates the BDNF. This is what I wanted to share because TMS does increase BDNF. So if anyone who's seen the documentary Quiet Explosion talking about TBI, I was excited. I was like, whoa, they have TMS here. And I didn't really understand how it helped, but I was happy to see that they were using that as a modality. So TMS does increase BDNF. BDNF is also what we know as responsible for brain healing and plasticity of the brain. And they found out with prolonged exposure to repetitive TMS, 5 days a week with a 2-day break for 11 weeks, they significantly increased the BDNF. So great option for people with traumatic brain injury because they need as much of this fertilizer as anybody else. So I want to pick on the MTHFR gene. There's a big mess here. So what it is we cannot use regular folate. It has to be broken down to L-methylfolate in order to take homocysteine and decrease the homocysteine, and then becomes methionine, and then becomes SAMe. And then depending on the amino acid attached to it, it becomes serotonin with tryptophan, and tyrosine becomes dopamine and norepinephrine. So MTHFR reductase deficiency, what happens is if you don't have the active form of folate, which is L-methylfolate, homocysteine sticks around, and homocysteine is what causes inflammation, suppression of neural stem cells, toxicity to the blood vessels, apoptosis, oxidative stress, impaired myelination, and development of plaques and tangles. So at the most, when it comes to MTHFR deficiency, you can see a decrease as much as up to 55%, and which leads you to a decrease in L-methylfolate. And of course, the treatment is 15 milligrams. What I want to tell you is that you can go through life and you could have this and you could be great. However, things happen, trauma, physical trauma, psychological trauma. Your brain, if it's functioning at only 50% and you have all this stress, that's usually the time that people wind up coming to see a psychiatrist. So sometimes it doesn't always affect you. However, when you have this environment that's asking more from you to produce more serotonin, dopamine, and epinephrine, and you just can't, this is where it's time to supplement. So I love this gene, the COMT gene, catecholamine methyltransferase. It breaks down two things, dopamine and estrogen. So here it is, dopamine gets broken down by the COMT enzyme to dopamine degradation. What is interesting is just because you have the COMT gene doesn't mean that there's one treatment. You have to look at whether it's high or low. So when you talk about when you have low COMT, which is low metabolism of dopamine and estrogen, this is what I call the warrior gene. In genetic testing, it will be seen as AA MET. So when you have high dopamine, you have worry, anxiousness, obsession, poor stress tolerance. And of course, when you have high dopamine, you can get psychotic. So, and of course, this can explain why sometimes I see, even in a female in her 50s, why is her estrogen high? It's not always the answer, but I was like, well, I'm not surprised why your estrogen is like this. And of course, when you have high estrogen, you're moody and overreactive. And but there's not a lot of it's not all bad, okay? Because people who have low COMT, when they're balanced and when life is good, they remember things. They have good executive function. You can rely on them to be meticulous. But there are some other diagnoses you see with low COMT, generalized anxiety, all the anxiety spectrum, autism. Autism, why? Because of the fact that they're super anxious. It's not that they don't want to socialize, they just don't know how to get past that. Obviously, PTSD, bipolar disorder. It's very interesting because when I was always taught to how to tell bipolar disorder in a female, that you ask them, hey, you know, what do you like before your period? It's like, I'm terrible, moods everywhere, you know? Well, maybe this is the reason why that you may have bipolar disorder. And postpartum and total hormone off balance there. And there are treatments now that like really focus on pregnenolone, allopregnenolone, and to help them get through postpartum. And of course, you'll see it in schizophrenia. And I always tend to get entertained when schizophrenics, I hear their story when they're younger. You know, they like their marijuana. And I'm not gonna down marijuana, even though I am an addiction medicine doc. But the thing is, people have to be careful. If you have mental illness in the family, you better not go there. So how do you treat it? Supplements, actually, lithium, magnesium, things that promote serotonin, because if you're running high in dopamine, you need a little bit more serotonin. And I usually use tryptophan and 5-HTP, GABA promoters, and pregnenolone. Why? Because it increases GABA. And we will avoid phenols, anything that makes dopamine, green tea, curcumin, quercetin, amino acids, L-methylfolate, SAMe, and high-dose B vitamins. And I'll get a little bit more into this later on. But this is the fun thing. When your COMT is high, when you're rapidly metabolizing dopamine, you are rapidly metabolizing dopamine and estrogen. But this is what we call the warrior gene. So as a result, though, the dopamine is low, the estrogen is low. You have symptoms of inattention, depression, sometimes apathy. And I like to think of this gene as the ADHD gene, really, because you can see it not only in depression and anxiety. You can see it a lot in ADHD, impulse control disorder, gambling, binge eating, substance abuse. This can explain why some people like their cocaine, their opiates, and their alcohol. So I no longer ask my patient, not just, why do you use it? Why do you use substances? But I ask them, how do you feel when you use the drugs? If they tell me I feel great, then I'm already suspecting this is what I'm going to find in their genetics. When they tell me they feel like crap, well, it's probably the opposite. And but as in society, and in mental health in general, we are only taught to use certain things like alcohol, like drugs, to get us to feel better. What I do want to say about these people is that they function great in chaos. They are great multitaskers. So these are the ones you don't ask them to be an accountant. You tell them you need to work in Wall Street and trade and stock and all that. You need to be in sales and so forth, or a CEO, because they come in, they solve the problems of whatever it is that's handed to you. So natural things actually treat people with high CompT. Anything with dopamine supplements in their ingredients, tyrosine, phenylalanine, any of the phenols, green tea, curcumin, quercetin, and amino acids. But wait, there's more. Now you understand about CompT and L-methylfolate. Let's talk about, there are complications when they're genetics. I did not understand this when I first started using genetic testing. I saw somebody with MTHFR deficiency, and they had low CompT, but I didn't know anything about that. So I gave them L-methylfolate 15 milligrams. Guess what? They got anxious. And I'm like, why'd you get anxious? That was supposed to work for you. So in these cases, we give lower dosages, 7.5, but even that will make somebody anxious. Because what happens? The L-methylfolate will still make the dopamine. So I usually give more serotonin supplements because it increases serotonin without increasing the dopamine. And I think at this time, SSRIs are appropriate for these kinds of patients. I am not against psychiatric meds because there is a place for them. But I would like to start with, what can I do as natural as I can to get my patients better? So MTHFR deficiency with high CompT. This is what I call the double whammy gene. You are low in everything: serotonin, dopamine, norepinephrine, because you have hypermetabolism of dopamine. At this point, this is what I do. I usually give L-methylfolate with tyrosine or any kind of phenol-like supplement that will make dopamine, that will give them extra to keep the dopamine at a decent level. And I always tell my patients, these supplements, they don't work right away, but it take anywhere between 3 to 6 months. I had a case where the patient did have the same combination issue, and he was on bupropion, which keeps dopamine around, but he was eventually able to get off of that. I gave him the L-methylfolate and tyrosine, and he was amazing. He was able to function, focus, no more depression. When you think about somebody who's low in all these neurotransmitters, they are going to be depressed. And it's nice to know that there is a biologic basis for why people feel bad. So let's move on to Brainwell labs. This is what I run with labs. The usual CBC, lipid panel, hemoglobin A1C, vitamin levels, even metabolites of vitamins, as well as inflammatory markers, and the hormone panel. I'm just going to pick on a couple of things for the sake of time because I think we're running short on it. I look at lipid panel a little bit differently. This article shows that cholesterol, mood, and vascular health, untangling the relationship. What they found is patients with mood disorders have lower levels of cholesterol. Why would that be? As you know, the brain cells are made of lipid layers. So if you starve your brain, your cells are not healthy. So they are not making things like serotonin, and it leads to depression and suicide. B12 deficiency, it is still a pathophysiology of depression because, as you know, any kind of B vitamin deficiency, you can have homocysteine that causes oxidative stress, damage to mitochondria, nerve cell damage, atrophy of the nerve cells, and decrease in their neurotransmitter signaling leading to depression. So this article actually showed B12 supplementation prevented onset of depression and improved the prognosis of depression. And yeah, I'm showing you this messy slide again, but I want people to focus on the B12 right there between the two circles. It's very important. So what you need to understand is B12 can result in depression because if you don't have enough of it, you're not going to complete this cycle. So how do we treat it, or what are the benefits of treating it? As mentioned, delays the onset of depression, and it can improve the effects of your antidepressants. Because as we know, SSRIs and SNRIs, even bupropion, they're not there to make neurotransmitters. They're only there to keep what you have around. So when do I treat this? When a patient is complaining of depression and their B12 is at 400, that's not optimal. So go ahead and supplement them. Usually 1,000 micrograms daily if they are low comp T, because you have to be careful, as you know, if you add B12 in there, it will still cycle into making dopamine. So I give a lower dose. Some require gastric bypass. Some with gastric bypass, they do require injections. And homocysteine, I look at homocysteine because there's different reasons why your homocysteine is elevated. And we know about B12 and folate, but MTHFR deficiency, oftentimes I look at somebody's labs and I see that their folate is elevated. I'm like, 50-50 chance that their homocysteine is elevated. So I check that because MTHFR deficiency, when the phenotype C677T, that's the one that can lead to elevated homocysteine. So, of course, B12 folate and L-methylfolate. And methylmalonic acid, why do I check that? I'm concerned if the methylmalonic acid is elevated. So that means also B12 deficiency. However, there are some people, a lot of them, if they are poor metabolizers of folate, they have MTHFR deficiency. They're likely to have also a poor ability to metabolize B12. So when I see a B12 that's high with elevated methylmalonic acid level, I immediately just give them methylcobalamin 1,000 micrograms daily instead of a B12. But I'm actually moving away from regular cyanocobalamin. It's really not good. So methylcobalamin, you're already giving them the active form. So I want to just point some things out on vitamin D deficiency. Does it help in depression? They did find that there is a role in depression and anxiety, and I found out the connection really is serotonin, that it is a cofactor for making it. And so they recommended everybody should get screened for vitamin D deficiency, especially if you suspect somebody is having issues with depression, or check their vitamin D and just supplement it. Maybe they'll feel better. I wanted to just talk about Epstein-Barr virus because a lot of clinicians really don't take any account in this, but it does cause a lot of debility, fatigue, myalgia. But what is concerning is that if you have mono in childhood, you have a 40% risk factor for depression. So the biggest thing is, as we know, it's really inflammation that's causing this. When we run the hormone panel, we now use the Millennium Protocol. Otherwise, I would not even give my patients this option. I would have no idea. So what we check for the brain hormones, pituitary, LH, FSH, TSH. We check your thyroid and adrenals and your sex hormones. Because Dr. Gordon has taught me to not be satisfied with telling somebody, oh, your testosterone's low, and then we're just going to give you those shots. I want to know why it's low. Is it the brain injury? Because we need to work on decreasing inflammation, supporting the brain for brain healing, and give supplements for the body to make these things until the brain is able to. And I'm not saying I wasn't a believer, but I was like, for sure, I saw it in my patient. We gave them all the supplements to support brain healing because he had a massive traumatic brain injury. That's why he suffered with recurrent depression, and he didn't know what else to do, but came to our office. And I worked hard with this guy 2 years. Ran the Millennium Protocol several times, and he took the product and to help him get better with his brain and heal. His luteinizing hormone was very low in the beginning, and it became normal. So I didn't have to give him any more supplements to stimulate that anymore from the brain. So it does work because I believe in the plasticity of the brain. We are designed to actually heal ourselves. We just need a neuropermissive environment to do that. So as we know, testosterone, when you're low, you can't have depression, but you can have anxiety as well as memory issues. They've noticed that if you supplement, your memory gets better. We have to be really mindful when we know, especially a young veteran who comes to us, because we're getting a lot of those from the VA, that have a history of it. So you better be checking their testosterone level, because brain injury can cause the pituitary gland to not function. So we need to check these things, because you can give all the SSRIs and SNRIs and adjunctive treatment, but the patient is not getting better. There's something else going on when you hear that a patient has a traumatic brain injury. You better be checking those hormones. And Dr. Gordon likes to say it's not treatment-resistant depression until you check the hormone. And he's right. So I want to just pick on allopregnanolone. Allopregnanolone is what we call the mother of all hormones. It has lots of functions. I'm just going to pick up a couple of them. It stimulates a GABA receptor, so it gets people to sleep and reduces their anxiety. As we know, this decreases in women in their 40s and 50s, because at that time, the body says you're no longer needing to be pregnant. However, we found that there are mental health benefits to having pregnenolone. So prior to me learning all about hormones, I just gave my patient Prozac, and I was like, here, this is what you need. That's why you're coming in here, and some benzos. And because this is the time that women will come to a psychiatrist or even their regular doctor, and they're complaining of anxiety. And this is the time where like they will get the benzodiazepines or the Prozac, because that was shown to help with premenopause and menopausal symptoms. Pregnenolone also, as I hear all the time with females, I can't remember anything anymore. I don't know what's wrong. The answer could be pregnenolone. So let's talk about environmental toxins. Why would I want to run it? And these are the top 3 that I usually look at: heavy metals, mycotoxins, and glyphosate. All these are inflammatory and damaging to the brain, and all of them will decrease neurotransmitters. But I want to pick on glyphosate. Glyphosate is like controversial, but this is a systematic review. They looked at all the journals, and they came up with certain conclusions about how glyphosate affects the nervous system and what it does and why it causes mental health issues. AMPA is the metabolite of glyphosate. It's neurotoxic to the brain. And then it causes oxidative stress and inflammation. But wait, there's more. When glyphosate not only causes cell damage, but it disrupts all these neurotransmitters. Glutamate and GABA, they come from each other and come from glutamine. Glyphosate disrupts that process. So you don't have any glutamate, you don't have any GABA. Dopamine, also, glyphosate will increase the metabolism of dopamine, decrease dopamine release in the cells, and then it downregulates the expression of genes in dopamine synthesis, degradation, and transport. So serotonin, it actually will work on decreasing the breakdown of it. So it wouldn't surprise me if a patient came to me and then I find that they have a lot of glyphosate in their system. We're in Florida, it is the worst here. So whenever I hear somebody saying that they're having fibromyalgia symptoms and so forth, classic example, I have my patient that was a functioning EMS, and she was amazing. She was pretty much bedridden, and they thought she had MS, and she did have some functional brain issues like tonsillar herniation and so forth. But the neurologist, and she's been to several of them, they couldn't explain why she was having these symptoms, and nothing was showing up in MRI. So I said, for kicks and giggles, come on, let's check your tox panel. She was almost 100% full of glyphosate. So now she's in a detox. There are days where she actually feels like she wants to go out and do things. So to sum it all up, once I know all the problems that are wrong with the patient, then I know what supplements to give. I may add medications to boost them faster because supplements do take time. And genetic testing will guide that as well. And lifestyle, depending on where you fall in your dopamine balance, I either tell people go run a marathon and go eat high protein if they're rapid dopamine metabolizer, or tell them they need to do more, less protein and plant-based and more organic stuff, because as we know in the environment, lots of endocrine disruptors. BPA is one of them that acts like estrogen. So imagine that in a patient. So I would tell those patients to use more relaxation exercises and go easy on the protein. TMS, if the patient is meeting criteria for it because they have depression, it is approved for that. It is approved for OCD, or if they had a traumatic brain injury, to get their brain functioning again. And if needed, I will stabilize their hormones. And if needed as well, even if these modalities are not doing what it needs to do, then I would tell people, go ahead and get your HBOT treatment. And we have a protocol for that, which Scott Scher actually helped me create. So we have all the things in this integrative treatment plan that can get people better with their mental health. But the whole point is, the main organ of interest is the brain. This is the foundation for what we should be focusing on in psychiatry. Because mental illness is multifactorial. You have genetics that play into it. You have toxins that ruin your neurotransmitters and your brain cells. You have trauma, psychological, physical, that can cause bad reactions in the brain. Maybe you're not eating that great, or maybe you're just deficient in certain supplements and vitamins. So we need to consider that. And is it hormonal? And so the main focus now, I've kind of switched away from mental health. And I wanted to focus on brain health, because if you're in psychiatry, you need to focus on the brain. This is not a Prozac deficiency. Something is going on in the brain that's not healthy. So let's work and find ways and how we can get that brain healthy again and get them functioning again. So I've come up with a program where I use all these modalities in what I call the Brain Well program. And as you see the journey I went through, and as you see certain things that I picked on, why certain things are important in the treatment and workup, genetics plays a factor in what supplements to give, what medicines to avoid. Genetics can tell me whether a patient is going to respond to TMS or not. Because if they are low in their neurotransmitters, easy fix. get them to a point where like they are producing those things normally, because you can do all the TMS you want, but if the patient is deficient in neurotransmitters, it's not going to be as effective. And of course, hormones to me is the last piece of it, because there are mental health benefits to hormones, but I like the fact that I am learning it from the beginning, addressing the beginning instead of adding things at the end with the hormones, which also shuts off your own natural production. So that's about it, what I do. I guess I can open up to questions.
Yes.
Mhm.
So first question is, what is the dose of lithium to increase BDNF?
It just depends, really. I just start with 5 milligrams, and then I go all the way up to 20. And sometimes I use like super low dose of lithium carbonate, no more than 150. And I watch their kidney function, and I watch their lithium level function to make sure it's not truly elevated. Because other doctors will ask them, why does your doctor keep your lithium level low? And I have to explain again, this patient, I'm not using it to treat their bipolar disorder or mood disorder. And I think that's the reason why lithium is a good adjunctive treatment. And if you can see, sometimes when we treat bipolar disorder, nothing works but lithium. Maybe it's because they're like low BDNF producers. And lithium comes in and helps increase that, gets the brain healthy. Okay. All right.
Okay. What about, just as a aside, lithium orotate over the counter?
Yeah, that's what it is. It's lithium orotate over the counter.
I'm actually doing MERT therapy. It's a Marine with TBI, similar to TMS, different location in the forehead. Uh, says a VA is covering TMS and ketamine. So, any experience with ketamine? I know that's all the rage.
Yeah, we were thinking about doing that in our modalities, but I between the two, I found more evidence that TMS has bigger reach in how to treat patients better. So, so I went with TMS route because of all the benefits that I've explained. That like it's an amazing treatment. Oh, there's a question about lithium safe in pregnancy. Yes. Why do I say that? Because everybody needs lithium in their body. There was a study in Japan where lithium was supplemented in the water versus the community that didn't. They had less depression, less suicide. And at times, our diet right now is so processed. The foods that we eat are so processed. We're losing those natural minerals that we're supposed to get from the earth.
Okay. Just a statement. Dr. Amen has stated that cannabis is worse on the brain than alcohol. By the way, everybody, next week's talk is by Dustin Sulak, who's going to be talking to us about cannabis. Just so you.
Yeah, it is kind of controversial, but I think they're both bad for the brain. I don't know, one is worse than the other. They both cause oxidative damage, and yeah, stay away from marijuana, especially if you have mental health issues in the family.
Hey, Dr. Damayo.
Uh-huh.
If I may, I think the cannabis, and Dr. Sulak, I bet you would probably agree with this. I believe the anasphyxiation, the lack of oxygen, I think is what's killing the brain cells. And I don't know if Dr. Amen has done any cross-examination studies with those that are doing only RSO, like cancer patients who are doing edibles or the Rick Simpson oil, and they don't smoke. It's the people who smoke who cut off, they take in the hit and they hold it. And then, so I think that's what's killing the brain cells. It's worse than alcohol. It's absolutely, it's off the charts. But what I'm getting at, since I volunteer with Dr. Clearfield, and Dr. Clearfield is trained under Dr. Gordon, and I've been learning from Dr. Gordon, and we believe 300,000 veterans have now killed themselves because they believed and they were told they have mental health. Dr. Amen wants to change psychiatry and psychology to brain health, not mental health.
Yeah, I mean, that's where I learned it.
I can't amaze. I'm pretty amazed at what you're doing, because you're actually using labs to diagnose what's going on in the brain. It's absolutely amazing. Have you ever reached out to the research department? And you know, this is hardcore. I know Dr. Gordon's dealt with this. The VA is, you know, very pharmaceutical. Let's put it that way.
Yeah.
Have you ever reached out to the VA and tried to get your counterparts? Because you know, I went into the psychology appointment, and it took me 2.5 months to get an appointment at the VA. This is why we think a lot of our vets are killing themselves. Have you reached out to some of their research groups? They got research departments at the VA that might be able to work with you.
Yeah, I'm actually like thinking about doing a proposal to propose this Brainwell program. The VA already sends me patients, so I'm already using it, and amazing results. I have one that came to me. This is the time I was learning about hormones and mental health, and so he got lucky. You know, I did the supplements because I found out what's wrong with his genetics, and he had a TBI, low T, depressed, and he said he's been depressed ever since that happened. And then we did the TMS, and then I added the hormone piece. He's not on any psychiatric medicines for the past 2 years.
And I'm the one who put in the chat. I'm doing with Dr. Zavala right now, magnetic E resonant therapy. And so he does magnetic resonant therapy based on your EEG and your EKG. So it's a little bit different than the TMS, because TMS is what the VA allows, but they don't allow the MERT. So the MERT puts the thing on your back, on your forehead, right here. TMS puts it over to the side, different load. And then depending on Alzheimer's and autism, they start to put it in the back. And if I go to 2 to 3 treatments, and a treatment is 10 series, if I go through 2 or 3 treatments and it doesn't work, he starts to go to the back. So that's the difference between MERT is the back and the front, and TMS is to the side. Have you experienced any of that?
Yeah, there was, as you know, the TMS is approved for anxiety. So the place for the anxiety really is we use it on the right side of the brain,
right,
instead of the left. So we sometimes have to add that, and that's the reason why it works better for depression and anxiety together. And unfortunately, I don't understand it. Insurances are still not paying for the OCD indication, but I always tell people, you have depression, you have anxiety, same difference, same chemistry. Unfortunately, anxiety is even harder to treat. So
the VA does pay for the TMS, though.
Yes, they do. However, I have a hard time getting authorization. I have been fighting with them about one patient who really needs it, brain injury, low T.
Right. You have to supposedly have major, which I do, major brain depression and or major PTSD is supposedly the 2 precursors. I don't know, if that's part. Well, it's insurance. Let's be honest.
Yeah, and so I don't understand why, and it's not even, I don't know who the think tanks there now, or the powers that be that are deciding this, but I was fired up when I realized the VA is supposed to be helping to promote alternative treatments, precise treatment, and then I don't even think the people that are denying this are even aware of this law. So I'm gonna fight that. I'm gonna write another appeal. Sometimes they do tee me off because the patient I was talking about, who's not on any psychiatric meds, he's on things to correct his hormone balance. For the longest time, they didn't even want to pay for his clomipene. And they were nasty. You know, they're like, why is your psychiatrist treating you with clomipene? You have depression. So I had to write a letter. Listen, the reason why he's depressed because he's low T. He had a traumatic brain injury serving our country. They finally gave it to him. But you know, it's a battle. But I'm hoping one day that we can finally really get to the point where like they're more open to this. I mean, let's get them quicker, better, faster. That's really the whole point of why we want to do this.
We have Stephanie has her hand raised, so
Okay.
If you're there, Stephanie.
Yeah. Somehow I lost the screen again. Hey, Mike Lord, can you come back and help me with this?
So are you there, Stephanie?
I don't know why I keep losing that screen.
All right. Well, I see questions. Okay. It says questions.
Okay.
All right. I don't know if she's here, but not answering.
I was trying to like click on the chat box.
Next question then is she comes back with us. What is your approach for EBV? I guess Epstein-Barr and treatment for it.
Really, the whole point of why it happens. Sometimes this is my own personal theory. Why they're no longer active, but their markers are so high. That tells me there's something else going on. I think it just really messes up their immune system. So when that happens, I actually tell them, hey, can you please agree with me to run an environmental tox panel? So sometimes we find things and we work on detoxing and removing those toxins. And then, of course, bring down the inflammation, you know, all the supplements that's needed to help bring down the inflammation.
Okay. Do you use low dose naltrexone at all?
I have. Not a lot. You know, some patients it does work. So I do use a compounding pharmacy for that.
Mm-hmm. Okay. H. pylori connected to psychological problems?
Yeah, I think it has to do with gut health.
Mm-hmm.
Let's go back to, I talked about vitamin D deficiency. It's fascinating. If your gut is not working well, then also with vitamin D deficiency, the gut produces serotonin as well as the brain. But vitamin D, supposedly, if you have too much serotonin in your GI tract, that causes inflammation as well. So vitamin D comes and tampers that. But it's interesting how in the brain, it increases the serotonin, the vitamin D. So there's still a lot to be known, but I always say, whatever you do, if you're going to detox, even mental health, you know, take a probiotic, a good probiotic that'll get your gut cleaned out.
How about the spore-based probiotics? Any difference between them and the bacterial-based ones?
No, I'm not really that familiar with them. So I'm dealing with a population like, okay, you know, you're gonna have to just try to experiment what works for you, because I don't really prefer one product over another.
Well, you have to stick with us then, you know, because we have the microbiome lab people are good friends of ours, so that we have them on quite frequently.
Okay.
What company do you use for genetic testing?
I use, you know, I mean, I'm not supposed to promote any of them, but
we're not CME here, so it's okay.
All right. Well, what I talked about, like most genetic testing do focus on like, okay, these are the meds to give, right? However, the only one company actually taught me the other way, like, okay, pharmacodynamics and what's going on, what were they born with? It's Genomind. They are great when it comes to how they interpret and how they explain, and they have lots of CME. So I use Genomind because they test for everything that I'm looking for. Not every test or every genetic test will test for all those things, but they do. So they give me
GENOLINE? Genomind?
Genomind. Genomind.
Genomind.
Mhm.
And so, what does a test cost?
Uh, Believe it or not, it's not that expensive. With insurance, it's $400. That's it.
And without?
Without, if you didn't have insurance at all, then it's going to be about 1,700. But most of my patients, are insurance covered, and so sometimes though I do have to use other genetic companies that are not as great, but they do work with people's income.
Mm-hmm.
So
Medicare, Medicaid? Do they-
Medicare, Medicaid pays for Genomind.
Really?
Yes.
Wow.
Yeah.
There's also GeneSight, and GeneSight's a little cheaper. It costs, if you don't have insurance, it's $330. And Medicare and Medicaid both pay for that. It's actually easier. They pay for it easily. The other
Yeah.
insurances
The-
usually don't. But yeah, but GeneSight is easier to read. It doesn't do such a good job as Genomind. Genomind definitely does a lot better, a lot more tests. But GeneSight will also, get you a lot of good information like the COMT and the MTHFR. If you, you're not supposed to promote this, but the drug rep, not drug rep, not pharmaceutical, sorry, the representative that talked to us, to my office about GeneSight, they said that if you didn't pay your bill for 3 cycles because of like you were having a lot of financial problems, the bill just sort of disappeared. But you're not supposed to say that.
yeah.
Um,
The only reason why I don't really prefer it because I don't understand why they will not test for BDNF, and I need to know this, especially in my TBI cases. So
yeah.
sometimes though, I'll be like, okay, I don't know what it is, but take this lithium. Let's see if it's going to help. If it doesn't help, then you don't have it. But
Yeah.
it
a
helps.
lot of the psychiatrists I know won't do the Genomind because it's much more convoluted and harder to read, they said. But it doesn't take that long to figure out, to look it over. It does give you so much good information.
Yeah.
So the GeneSight's just a little easier to read, but like you said, it doesn't do a lot of the ones you would like. I did have a question for you about the COMT gene. So like I understand the met and the vowels, but what about when you have a met vowel?
Oh, that's normal functioning, and I'm not worried about that. I mean, I did read further along that it's still a high metabolizer, but not as high as the valve. So when they're valve met, I'm like, they're fine.
Okay, so I also had a question about the TMS. I only just recently was certified to do TMS myself in the last 6 months or so ago. So it's kind of new to me.
Yeah.
And I actually just recently heard about them using TMS TBI. So I actually have a TBI. So I was looking into that myself, and I came across there's actually like a site of people that have had not bad responses, a bad outcome, I guess you would say, from TMS, and they were describing symptoms of a TBI and saying that TMS gave them a TBI. So I was just wondering if you had heard anything about that.
I haven't heard anything about that. It gave them a TBI. That's new to me. The TMS doesn't come without its risk. Okay, seizures and but that's really the worst thing, or worsening migraine headaches and so forth. But I've not come across where TMS will do that. So that's something new to me that I haven't heard.
Yeah. I just wanted to throw out there also that I've been doing what you've been doing for a long time, pretty similarly. The only thing is on my wheel that you have, I add 2 things. Of course, therapy is
Yeah.
another. I kind of put it as a puzzle piece. So we've got the supplements, the diet, the exercise, and probiotics is my other besides the hormones, is my last piece to help get the intestines healthy. So I've seen, like in autism, children getting like within 6 months of going on probiotics, getting like speech and amazing things happening. So definitely healthy brain, healthy gut, healthy brain. So that's another thing that I added because I've been doing basically integrative psychiatry for quite a few years now. So that's the last piece that, like I said, I have a wheel similar to yours, but mine's, I call it more like a puzzle. All the
Yeah.
different pieces, each person, it's unique and it's treating the brain, the body, But anyway, just
Yeah.
wanted to add my 2 cents in.
That's good. That's good that, there are other like-minded thinkers out there, because I think we have to come to that decision that we got to go beyond what we do know. But I think there's really no excuse not, because there's so much more technology now that we have access to. That's that we got to, get out of the box of like, this doesn't work, then try this, try that. Because, yeah, that has been a difficult challenge for me, trying to get my patients better.
Jenny, Dr. Zavala, he's got 80+% success rate with his magnetic resonant therapy, which is a form of transcranial magnetic stimulation. And he says that the people who complain about what doesn't work are the ones that are still smoking weed and still drinking alcohol. And he tries to tell all of them, you've got to stop that stuff. And if you don't change your lifestyle and you don't change who, this whole process goes through while you're doing the treatment, it doesn't work.
Yeah, it's the whole point. Like, I noticed that too. Like, why did some of these patients didn't respond? Because they were full of inflammation. I didn't understand that inflammation is a big factor in how people can get their brain healed. And I always tell people, I can give you the best cocktail out there, but if you're still like drinking, drugging, being in toxic relationships, not using your coping skills, not getting out and getting sunshine and connecting with nature, it's not going to work. Yeah, it is. The whole point of why we do this too, that, I didn't really mention that much about it, but like, yeah, we do have, nutritionists, and of course we believe in therapy, and we can refer people to personal trainers and dietitians and all that, and life coaches, because some of them just really have a hard time trying to even gather around the supplements and so forth. It is pretty extensive. The good news is that we tend to wean a lot of it down when the patient's brain gets healthier. Okay. All right.
Great.
I think that's it. So,
Anybody else have any comments or questions? Well, Dr. Damayo, one of the unfortunate consequences of giving a great talk is that we're going to want you to come back.
I would love it. Paul, are you saying hi or you have a question?
I have a question really quick. Back to the Epstein-Barr.
Yeah.
Naltrexone. What is it? And I'm told 5 milligrams or less. And I'm also told, and you're going to laugh, 5 Brazil nuts a day because of the selenium. No more than 5. No more than 5 because you'll get toxic.
Yeah, I mean, if you're sticking to a safe level, I don't see why that's an issue. As we know, all these minerals are very important, not only in helping you stay healthy and helping your immune system, but it does also play a factor in like hormone balance. If you
Is the naltrexone, what type of drug is that?
It's actually the opioid antagonist or opioid blocker, and they noticed that super low dose has anti-inflammatory effects.
Gotcha.
So
Thank you.
That low dose. Okay.
Hey, Doc, did you answer Stefan's question about lithium orotate, low dose,
Yes.
5 milligrams?
Yes, I did. Okay.
Stefan's not a big fan of Brazil nuts, by the way.
Gotta do iodine and meat.
Okay. All
Okay.
right. Okay. Well, thank you so much, everybody, for showing
Thank
up.
you. We really appreciate it. We appreciate your time, and we appreciate you being here. I know you've been with us for a few weeks. So next week we're going to have Dustin Sulak. Dr. Sulak's going to talk to us about cannabis and all the wonderful things that it does. So maybe you two can arm wrestle or something. I don't know.
Maybe. All right.
John,
Have a good night.
you have anything for us? You there, John? You figured out how to use this system yet? We've been on this system a couple of weeks now, so we're getting better at it. We didn't lock the speaker out like we did last week, or the speaker was talking and no one could get her attention.
Yeah, that's exactly my fear. I was like, let's make sure this is fine. But
Yeah, no, we're doing better this week. So we had Kyle with us, our tech guy. So
yeah, good. But anyways, I want to say, props to you.
Thank you so much. Next
Thank you for showing
next
up.
week we have Dr. Dustin Sulak. The week after that, we're going to have Beth Shirley. She's going to be talking about not sure what she's going to be talking about, but we'll get on that. And I will be away in 2 weeks, so we'll have some other hosts for you. And I will be at. By the way, we'll be at Dr. Farshian's soiree in Miami. For the American Academy of Stem Cell Physicians. That's one of our sister groups. They're on Wednesday nights. If you ever need, if you want a link there for, they do a lot of the regenerative medicine. Dr. Halas is on Monday nights, and they're part of our group also. And so, we have every night of the week you could be here listening to, some of the stuff you're not going to get in the mainstream medicine. So, John, did you figure out how to turn on your mic yet? Or it's time. No. So maybe I can do it. I'm not sure. So, anybody else have any comments, questions? Thank you all so much for being here as always. Dr. Gordon, thanks for being around. Let me see if I can do that. Turn mic off. So, John, I think your mic should be on. Still no? Okay. Never mind. We'll figure it out. Okay, everybody, thank you so much. Thank Dr. Damayo. Thank you enough. And it was really great. And we'll see you all next week, same time, same station. And again, if anybody, please let me know if you want if you have anything you'd like to present, because we always need some presentations. AOSRD.org, we can get the video, or it's been going up on my YouTube channel. I have a YouTube channel, big deal. Clearfield Medical Group, so it'll be there also. And then we'll take it from there. So good night, everybody, and we'll see you again next week.